Greetings, I'm the dentist. In our DENTAGENDA, we will be continuing the second chapter, Preventive and Community Dentistry. Point number 2, Caries Diagnosis. As caries can be arrested or even reversed, early diagnosis is important. Caries detection methods. In this tutorial, I will explain the caries detection methods from the conventional to the most recent techniques available. Starting with method number 1, the visual method. If the tooth is decayed, you can notice change in the appearance or color. It starts as a white lesion or a white spot that then stains and becomes brown or black. Magnification between ×2 and ×6 loops is better. Method number 2, tactile caries detection. The surface of the decayed tooth becomes rough and catchy when examined using Dental Explorer, and you can determine the approximate depth of the cavity. A blunt probe should only be used to horizontally dredge plaque away from the fissures, as a sharp probe may actually cause further damage in an incipient lesion. Number 3, temporary teeth separation. Using elastic separators to visualize the proximal surfaces, it makes it easier to restore it as well, and afterwards the teeth tend to return back to its original position. Radiographic examination. Bite-wing radiographs are the most accurate. Caries appears as a radiolucency, even if the surface appears intact clinically. However, it is thought that the probability of cavitation is low when the lesion is confined to the enamel only on the radiographic image. Number 5, caries detection dyes. Different dyes have been used to detect caries lesions, some to detect caries enamel like prucine, calcine, and brilliant blue, and others to detect caries dentine like basic fuchsin dye, but it is carcinogenic, so it can be replaced by either methylene blue or acid red. When you apply the dye, it clings to the lesion, and it shows you the extension of the caries. It can also be used to detect tooth cracks. Number 6, fiber optic transillumination. The light transilluminates the tooth surface, allowing you to see the caries lesion as a dark spot, even if it wasn't visible on the tooth surface. This light can also be used to detect dental cracks, just like caries detection dyes. Number 7, quantitative light-induced fluorescence. This optical technique uses the natural fluorescence of teeth to discriminate between caries and sound enamel, based on the fact that the fluorescence radiance of a caries spot is lower than that of the surrounding sound enamel, so it appears as a dark spot. One of the recent methods to diagnose or detect caries is the diagnodent. Diagnodent is a pen-like handheld tool that is used to scan the tops of the teeth. It's able to find cavities that are easily missed on X-rays and are not visible during visual dental inspection. Diagnodent uses advanced laser technology to measure the density of the tooth enamel by sending a safe and painless laser beam into the tooth to measure the internal fluorescence. This laser operates at a specific wavelength, and it has two-way optics to quantify the amount of light reflected back out of the tooth. Number 9, electrical conductance. It measures the difference of electrical conductivity between sound and caries tooth structure. It should be recorded in the absence of saliva to avoid injury to the surrounding soft tissues, and it is mostly useful to detect occlusal caries. Number 10. Terahertz pulsed imaging, or TPI. It can be utilized in the early detection of dental caries and defects in tooth structure without using X-rays. 2D images can be obtained, and the caries lesion appears as a dark blue area. Number 11. Cariescan. It is one of the most recent methods used to detect caries. Cariescan is a small, lightweight, battery-operated caries detection device. It is quick and easy to use, automatically calibrated, and Bluetooth-enabled. It can capture readings wirelessly. Cariescan offers the earliest possible detection of enamel caries. This unique device provides accurate and repeatable data to monitor caries over time. Now we are going to discuss how to manage the problem you have detected. Before all, remember, pre-cavitated lesions can be prevented from further damage, and cavitated lesions could be prevented from spreading deeper by removing the caries and apply a restoration. Counsel the patient that if the lesion is not cavitated yet, it has the potential to arrest. This makes the preventive advice very relevant to the patient, increasing the chance of the patient acting on your advice. A case that you may encounter is smooth surface caries. Smooth surface caries occurs where there is no pits, grooves, or other faults on the tooth surface. It occurs in areas where bacterial plaque collects, such as between teeth, along the gum line, and in difficult-to-clean areas. This is relatively straightforward to diagnose. The chances of remineralization are obvious and accessible for cleaning. Restoration is indicated in the following events: if prevention has failed and the lesion is already cavitated, if the tooth is symptomatic or sensitive, and if aesthetics are compromised. In these cases, you should apply anesthetic restoration. Another case would be pits and fissure caries. This is difficult to diagnose reliably, especially in the early stages. Testing the suspected cavity with a sharp probe is discouraged, as catchiness could be due to the morphology of the fissure, and the probe could encourage cavitation. The anatomy of this area tends to favor the spread of the lesion, which often occurs rapidly. As fissure caries is less affected by fluoride application and oral hygiene measures, the solution would be fissure sealant application. It is preferable particularly in high-risk individuals, and it is best in early ages. Another scenario is approximal caries. If the interdental lesion is confined to enamel on a bite ring radiograph, only institute preventive measures and keep under review. But if the lesion has penetrated dentine radiographically, a restoration is indicated in this case, unless a serial of radiographic images show that the lesion is static and not progressing over time. If in doubt whether an approximal lesion has cavitated or not, an elastic orthodontic separator may be fitted for 3 to 7 days to allow surface visualization. Then, teeth tend to return to its original position. Finally, we will discuss how often should your patient show up for a dental checkup. Recall intervals. This subject has evoked considerable controversy. Some argue that regular attendance puts a patient at more risk of receiving replacement fillings, while others contend that regular and frequent checkups are necessary to monitor prevention. In fact, the available evidence suggests that there is no clear benefit for recall intervals of less than 1 year, for healthy patients, although the at-risk individuals often need to be seen more frequently. In the UK, guidance from the National Institute for Health and Care Excellence recommends that dental recall should be determined by the needs of each individual based on a risk assessment of existing disease progressing or new disease developing. For adult patients, this interval can be between 3 and 24 months, and for children, it is from 3 and 12 months. A child's first checkup should occur once the first teeth have erupted, usually the lower central incisors between the age of 6 months and 1 year. And here you have it all. Thank you for watching. Don't forget to subscribe. I'd like to have you here for more videos. And follow us on Instagram at DENTAGENDA for extra tips and tricks.